Welcome everyone. I'm Diana Royce, Managing Director and COO of AllerGen NCE Inc., which is hosted at McMaster University in Hamilton, Ontario. I'm pleased to extend a warm welcome to each of the 89 registrants participating in today's webinar. So welcome everyone. AllerGen NCE is pleased to offer investigators, trainees, collaborators, partner organizations, network advisors, and representatives from our sister NCEs across Canada access to complimentary webinars on research, knowledge mobilization and commercialization, planning, and best practices. Since its recent NCE renewal to 2019, AllerGen is intensifying its focus on enabling the achievement of network legacy endpoints and on helping research leaders, their teams, and partner organizations to sustain collaborative research, knowledge mobilization, and commercialization endeavors post-NCE support. So this webinar is being delivered at an opportune time to build translational capacity within the broader AllerGen and NCE community. We're pleased to have with us today Dr. Antoine Hakim, Professor Emeritus of Neurology at the University of Ottawa, who's also the former CEO and Scientific Director of the Canadian Stroke Network, which was funded as an NCE from 1999 to 2014. This afternoon, Dr. Hakim will share with us his insights and lessons learned regarding leveraging research evidence to change both public policy and healthcare delivery on a national scale. It's with great pleasure that I turn the session over to our guest presenter, Dr. Antoine Hakim. Dr. Hakim is Professor Emeritus in and former Chair of the Department of Neurology at the University of Ottawa, as well as Division Head of Neurology for the Ottawa Hospital. He was also Director of the University of Ottawa Neuroscience Research Institute and Founding Scientific Director for the Heart and Stroke Foundation Centre for Stroke Recovery. He was made an Officer of the Order of Canada in 2007 and was inducted into the Canadian Medical Hall of Fame in 2013. One of Dr. Hakim's crowning achievements was his leadership of the Canadian Stroke Network, an NCE that united researchers, clinicians, and healthcare workers in partnership with universities, governments, and not-for-profit organizations in an effort to alleviate the burden of stroke on patients and their families and educate the public on stroke prevention. As CEO and Scientific Director of that network, Dr. Hakim championed the Canadian Stroke Strategy, which most Canadian provinces have since implemented. We look forward with great anticipation to the details surrounding this groundbreaking NCE achievement. Dr. Hakim's presentation is entitled Planning for Policy Impact, Lessons Learned. He'll kick off his presentation with an overview of what is needed to change the healthcare system. In his first slide, he describes the 7 key conditions that are required to change the healthcare system, beginning with leadership, commitment, and support.
It's absolutely essential, and your NCE certainly has that. Key stakeholder involvement in terms of the involvement of the scientists in the group, the partners in the group, and everybody who is within the network needs to feel that this is very much something that they want to participate in. The next one is important because it talks about evidence. And here I want to say that the evidence that your network gathers is the evidence that I'm now referring to. It is the information that you have collected to, at least in the case of the Canadian Stroke Network, we wanted to not only know what the risk factors were and what the incidence of stroke was, but also what the outcomes were. With the evidence in hand, and number 4 says that it takes money and it takes patience to collect this evidence, you then have the tools that you need, the information that you need to educate at all levels, and from there bring changes to the practice of your particular specialty. So, the mission of the Canadian Stroke Network was one that at the very outset said what we wanted to do is to reduce the effect of stroke on the lives of Canadians and Canadian society. This meant as I will mention later, that we felt that our job as a network of centers of excellence was not so much as was expected in those days around 2000, to develop intellectual property and to develop it into small companies that would then have shares and sell them, and so enhance the economic activity in Canada. What we said was, what we wanted to do with this network is to impact the lives of Canadian citizens, which was a dangerous thing for us to do at the time, but as it turned out, it was a successful thing to do. And we wanted to place Canada at the forefront of stroke research by translating the research that we were performing within the network into health and economic benefits. The research that we did, so I'm going to go through some of the pillars of the Canadian Stroke Network. We had more than 100 researchers. Our network had essentially most, if not all, of the researchers in stroke in Canada, and a number of high-impact projects were continued. And you know, to this day, some of the projects that we started are still continuing within Canada. For instance, there is a clinical trial going on right now to look at the possibility of neuroprotection in stroke to be given at the same time that TPA is given to stroke patients. We made a big effort at training the next generation of stroke researchers and stroke practitioners, and the reason for that was that between the time that we started in 2000 or 1999 to the time that we ended, the definition of stroke from a condition that you couldn't basically do anything about had changed to be defined as a reversible condition that could be treated if one followed a number of parameters, particularly regarding the interval of time from the onset of symptoms to the reception, to the administration of a drug. So we needed to then train a new group of people with the new paradigm of stroke. I talked about evidence right at the outset, and one of the more expensive but more effective things that the Canadian Stroke Network did was to develop the registry of the Canadian Stroke Network. It was information that we gathered in this registry that allowed us to then put pressure, if you wish, in quotation marks, on our political leaders to make them understand that we in this country had a problem when it came to stroke care. It was information that we obtained in the registry, and this was that we in fact hired nurse specialists to go to more than 20 sites within this country, sit there and say, in the emergency room, can I look at the stroke patients who have come into your emergency room? Find out when did they arrive, how long was that from when the symptoms started, how long did it take for the medical system to respond after they arrived to the emergency room, did they or did they not get a CT scan, did they or did they not get a treatment. That was the information that we gathered on the ground in emergency rooms. And from there, we linked this data to administrative databases so that we knew for that particular patient who had suffered a stroke and had come to the emergency room, what was the previous history, what were the previous vascular risk factors that that patient had suffered from. And we collected more than 10,000 patients into the registry. That for us was the ultimate weapon, if you wish, by which we changed the response systems, and I'll come to more of that. In addition to the registry, we decided that we wanted to get into public education. It wasn't enough that we knew that from symptoms to treatment no longer than 3.5 hours had to elapse. It was very important that patients also knew that now a treatment was available. So we really got into public education in a big way. But we knew that we were, as a network, not going to be able to afford TV time to tell people to come to the emergency room when they feel certain symptoms. And that was really the genesis of the idea that we needed to get into a partnership and develop a stroke strategy with the Heart and Stroke Foundation, which I will come to in a minute. So we had partnerships with drug companies. We had partnerships with new small biotech companies that we set up ourselves. But really the biggest partnership was the Canadian Stroke Strategy, which was a partnership between the Canadian Stroke Network and the Heart and Stroke Foundation of Canada. As it says right here on the slide, this was the framework that we followed to change policy and practice where healthcare is delivered. So the Canadian Stroke Strategy was a combination of what the Canadian Stroke Network was doing in terms of coordinated research, gathering information on the ground, the professional development and training the next generation, as I alluded to, the development of standards of care. We set up many committees that said, here is what you have to do when the following situation arises, all the way from prevention to treatment and rehabilitation, and then public awareness. All of that crossed all of the thresholds from prevention to treatment to rehab to re-engagement, but it was really in combination with the Heart and Stroke Foundation. Remember that the Heart and Stroke Foundation at that time were 11 provincial organizations. Each province had its own Heart and Stroke Foundation, and those individuals and offices were connected with the political stratum in their particular province. So we knew that through the strategy and our partnership with the Heart and Stroke Foundation, we would have more easy access to people who are deputy ministers of health and ministers of finance, ministers of health in the different provinces. The knowledge translation, we decided what needed to happen was public awareness campaign, and so the Heart and Stroke Foundation, in fact, bought time on TVs. I don't know if any of you remember, but I certainly got I could recite the ads. I had been seeing them so often on television, set up by the Heart and Stroke Foundation to educate the public. So a large public awareness campaign. We continued the surveillance system. We, as I said, put groups of people to look at best practices and standards, and continued with the training program as we continued to carry on with the research that we were doing. The next slide shows all of the things that the CSN has accomplished, and I'm not going to go over this slide in any detail, but you can see the spectrum of things that we did. The registry data linked to administrative data, that was a big one. The NCE concept, the CSN developed stroke best practice guidelines. I think basically I've covered all of the items on the slide in terms of the CSN's accomplishments. So the next slide shows you how we lived up to the hype of saying what the CSN was going to do is have an impact on the lives of Canadians on the ground. When we, a couple of years after we came on, if patients came to the hospital within the 2.5 hours after the stroke that everyone said to them, that was the limit. Please come in within that time to the emergency room. In 2002, only 8% of those patients coming to hospitals in Ontario were able to get TPA. Towards the end of our mandate, 42% of patients who came to the emergency room within the 2.5 hours were able to get TPA. These people walked in with a stroke, and in many cases were able to go home the following day. having received TPA, provided they came in at the right time. But between those 2 points, data points, what we had to do was educate not only the public, but ambulance attendants, emergency room physicians, radiologists, so that they could turn on the CT scan rapidly. From there on to neurologists who suddenly were being on call when in fact they never used to come to the hospital in the middle of the night. Suddenly they were called upon to come in. And from there to talk to the healthcare decision makers about the need to continue to support this kind of activity. And here is the last slide that shows you the impact. The impact is that in Ontario, the Ministry of Health in Ontario said, wait, to its hospitals within Ontario, wait a minute, if you're not following the guidelines of the Canadian Stroke Network, it's going to hurt in your pocket. We're going to have to make a correlation between your budget and whether or not you are following the guidelines of the Canadian Stroke Network. So our job was done, and that's the last slide that I have to present to you. Thank you.
Well, thank you very much. Marshall, can we move back to the bar chart slide for just a minute? This really is showing the impact in terms of the before and after picture. And Tony, I think it would be really interesting if you could share with us some of your insights around the barriers and what the network had to do and what you personally had to do. I've had the opportunity to talk to you about this before, and maybe you could just tell us a little bit more about the issue around emergency personnel and municipal regulations that you had to change to enable people to get to the hospital in a timely manner when they called for an ambulance.
Absolutely. I mean, those are excellent points. First of all, in this business, I learned early that I had to develop thick skin. I remember giving conferences talking about TPA, and a couple of times someone at the back of the room would put his hand up and say, the only reason you're telling us about TPA is that you're on the take from the drug company that makes it. I just want to say that I was not on the take from any drug company at any time. But people will say these things. Our having informed the public with the partnership of the Heart and Stroke Foundation, the medical attendants in ambulances would say to us, I'm not going to put on my sirens and turn on my lights for a stroke patient. I'll do that if they fall down and break their hips. But there is nothing you can do for stroke patients, so I'm not going to put on the lights and put on the sirens. And so we set up courses to offer to ambulance attendants so that they would begin to understand the urgency of doing this for stroke patients. Other ambulance attendants said, because what we did was go around and identify hospitals that had an emergency department that had been educated, a radiology department with a CT scan that needed to be able to turn it on any time of the day or the night, and neurology on call. And so once we identified those hospitals, the ambulances were directed to go to those hospitals. And some of them came to me and said, you know, that hospital is only 4 kilometers away from where I am, but it is across a municipal line, and I'm not allowed to cross it. I can only take the patients to a hospital that's 6 times farther, but it is the one that I'm allowed to go to, and that hospital would happen to not be set up to take care of stroke patients. And so we had to go to the municipalities and really put a lot of pressure on them to remove that barrier from ambulances to cross municipal lines. And it just goes on and on. I can tell you that my emergency room colleagues, physicians in the emergency room, initially didn't want to have anything to do with deciding whether a patient who came in with a stroke would or would not get TPA, because they didn't want to take the blame, if you wish, for the occasional conversion of a bland stroke into a hemorrhage, and that happens. But we got radiology involved because they would be able to decide from the initial CT scan whether there was a trace of blood that implied that that patient should not get TPA, which is why the bar graph shows that you're only able to give TPA to something like 40% of stroke patients, because that is the theoretical maximum. It's not going to get much above that for a variety of contraindications.
Excellent. So we can open it up to questions, and you can type your questions in, and Marshall will read them out. And you can raise your hand on the control panel there, and Marshall will read out your questions. And in the meanwhile, I'll continue to pepper Tony with questions from the AllerGen Administrative Center. Tony, you mentioned at the beginning that it was a big risk for your network as you were, I guess, you were preparing for your midterm review or your second 7-year strategic plan, I think it was, to sort of minimize your focus on commercialization within the NCE strategic plan that you put forward, and to really put all your eggs into the knowledge mobilization, knowledge translation, quality of life basket. Can you set the context for that decision and how you came to that as a network? What process led you to make that kind of decision?
Well, we looked at the traditional format of networks of centers of excellence, and I mean, networks of centers of excellence were created to provide an economic engine to Canada. It wasn't really about taking care of people's brains or providing a defense against food allergies or anything like that. It was really to be an engine of growth. To lead, therefore, from networks to small biotechs, etc. We were lucky because when we started out, that's how we started out. But very quickly it became evident that stroke was a major economic burden, that unless the treatments and the other therapies for prevention, and unless methods of rehabilitation were brought to the level of the population, this was going to have, not doing something about this, was going to have a tremendous detrimental effect on Canada's economy. And so we were again very lucky in that context. A few things became available as early research projects, and one of them was the availability of TPA, but also a lot about prevention and a lot about rehabilitation. And we sat down and calculated if we had an impact in these spheres around stroke prevention, treatment, and rehabilitation, the impact that we would have on Canada's economy. And so we put all that together. We had a few experts come to our midterm review, end of the first cycle review in 2007, and we convinced the panel that was reviewing us that was really allowing us to continue in that direction was going to have an incredible impact on Canada's economy. And in fact, I remember that we also asked for a significant increase in our budget, and they granted us both. So it was just, we made what was evident to us, quantified and put numbers around it, and had health economists work with us in writing the renewal proposal, and had people on the ground come in and say that we were right in presenting it this way.
And there's a real lesson in that for all of us. Thank you, Tony. Marshall has informed me we have at least 6 questions for him to read out. So Marshall, take it away.
Okay, thank you. I'll read them in the order they were received. And the first, it was submitted by Kevin Willison. And this is the question. To encourage collaboration, interprofessional education initiatives in Ontario was encouraged. Does this appear to be getting less emphasis now? And if so, why?
I'm not sure I would be the best person to answer that question. I can tell you that in the field of stroke, we're still talking about interprofessional collaboration and education. Since our network has ended in its normal lifespan, there have been further developments in stroke therapy. By that, I'm referring to the fact that now, in addition to giving a stroke patient TPA, the patient is taken into radiology, and interventional radiologist, under certain circumstances, is able to put in the catheter and go to the clot that is now impeding perfusion to the brain and grab it and pull it out, with tremendous impact on the recovery of the patient. And so stroke neurologists are talking to interventional radiologists, and I can go on from there to the fact that now the ambulance that contains a patient with a stroke is ahead of time calling the emergency room, saying that they are coming. And now some ambulances outside of Canada are equipped with a CT scan to take images of the patient while they are being transported to hasten their access to drugs. So communication and the transfer of knowledge between different subspecialties continues unabated.
I'll go on to the next question, which is submitted by Michelle Howard. And the question is, could the speaker elaborate on the concept of an earlier slide, simple changes in practice should be implemented first?
Yes. I think that if you go to a deputy minister with a very large program, they're going to have a very hard time. Let me go on a small side thought here. Politicians mean well. That's why they enter into the difficult life of politics. They want to do the right thing, but very quickly their vision becomes focused on the fact that they are around for 4 years, and that what they need to do is to show impact, progress within their 4-year mandate. And I learned this lesson the hard way. I remember talking to the Minister of Health in Saskatchewan, talking about the entire spectrum of stroke activity, from prevention to treatment, in the emergency room, getting ambulances there quickly, educating the public, rehabilitation. He said, stop. Can I close beds if I do what you're asking me to do? To him, that was his focus. And so I learned before I open my mouth and go across the entire story, to find out where the deputy minister or the minister, where is he coming from? Where is she coming from? What are their stresses and pressures? And it became very evident that going in there with this massive program, they just their eyes glaze over, and that simple things. We want the ambulance drivers in your jurisdiction to turn on the lights and the sirens and give stroke patients precedence. Simple things like that, they were able to understand and able to implement. And I can go on and on. I mean, you know, we partnered with Manitoba to set up prevention clinics because they were willing to learn from us the fact that giving patients with vascular risk factors therapies prevented the stroke from happening, and they partnered with us for that. So that's what I mean by simple things have traction. If you go in with the complicated charts, they will glaze over.
The next question is from Danny Curry, and who asks, what do the data since 2010 tell us about maintaining the gains?
It's a very good question. We have recently seen a review that has been published. If you wish, you can look up Michael Hill. The paper, and I'm a co-author on it. The paper was published, I think, in Neurology. What we did was to look at in-hospital death from stroke across Canada, province by province. And it became very clear, and this is why the paper got published, that those provinces, and it's most of them, I'm proud to say, that had accepted to implement a stroke strategy within the province showed much lower death rates from stroke within the hospital than provinces that still had not brought in a stroke strategy. In other words, all of the coordination of patients with ambulances, with emergency rooms, with radiology departments, etc. Those provinces that had not done that had brought in showed a much higher death rate from stroke in their hospitals. So the gains continue, the impact continues, and it was articles like that showed the evidence. We had the evidence, and we went to deputy ministers of health and said to them, look, your province is falling behind. Here is the information that we have. I'm not going to mention which provinces, but you can get that information. And there it became a matter of protecting the political turf. So they would say to me, when is this report going to come out? I would say, well, we're going to finalize the data, and I said, it's probably going to come out in 5 or 6 months. And so just being able to sit down and say, your province is not looking as good as others, and the report that's going to indicate that is going to come out in 5 or 6 months, made some of them hurry up and do something about it, so that when the report came out, they would be able to say, oh, that's old information, we've already fixed this problem. So yes, the gains are continuing, and the pressure on the laggards is continuing. Witness the paper that I referred to.
The next question is from Lori Harada. It includes a comment, which I'll read first, and the comment is, excellent overview, congratulations to you. Her question is, what funding was allocated to develop and implement the strategy? Was Heart and Stroke Foundation's cost for doing the public service announcements included in this?
Thank you. That's an excellent question. We knew that we were partnering with somebody who had deep pockets. Please understand that when the Canadian Stroke Network first came on in 1999 and 2000, the Heart and Stroke Foundation wanted to know whether we were a threat to them. We were not. We were simply ready to do what the science had taught us and what clinical research had taught us. And over the first 3 or 4 years of our existence, there was this, I'm watching you and you're watching me, and between the Heart Stroke Foundation and the Canadian Stroke Network. We made sure that they were involved with us, that there was representation from them on our board. We made sure that we were not a threat to them. For instance, we had to make a commitment that we were not going to go fundraising for stroke, that fundraising was going to be done by the Heart and Stroke Foundation, that if a person who benefited from the activities of the Canadian Stroke Network came to us and said, I want to give you $1 million, we would say to them, give it to the Heart and Stroke Foundation. So we were able to establish trust with the Heart and Stroke Foundation over the first little while. And so, no, we did not pay for the ads. when we developed the strategy, they put some money on the table and we put some money on the table.
Our next question is from David Phipps. The question is, there is a long way between evidence and impact. What was the role of Heart and Stroke Network in advocacy? What did they do that CSN didn't or couldn't?
Well, I invite you to see how expensive it is to buy time on TV. We couldn't afford it, nor I think would the network of centers of excellence have allowed us to do that. And frankly, it wasn't just a matter of money. It was also that the Heart and Stroke Foundation had the contacts. Every province had a Heart and Stroke Foundation office. The mandate of those 12 offices across the country was to be in contact with the political sphere and the political managers and people who made things happen at the political level. And so the partnership, if you wish, was one of mutual benefit to both sides, which is really how every successful partnership is. They benefited, the Heart and Stroke Foundation benefited from our new science discovery, from the impact that we had on emergency room physicians, emergentologists, ambulance drivers, radiologists, neurologists, etc. And we benefited from their contacts and connections. It was really a partnership. I don't know what would be the equivalent partnership for AllerGen, but it would be fantastic to find an organization that would have the connections, the contacts, the presence that we were successful in finding with the Heart and Stroke Foundation. Thank you.
The next question is from Susan Elliot, and it's a multi-part question, so you can ask me to reread it if it's hard to keep track of them all. And the questions are, how did your board feel about the shift in direction to KT? What was the greatest hurdle you faced in developing this process? You faced a lot of pushback. What was the tipping point for change? Was it the recognition of the economic impact? How long would you say it took to develop the strategy from beginning to end? And now that the network has ended, what, in your view, makes the strategy sustainable?
So we're going to have to repeat some of these, but I've taken notes quickly. Yes, very important to have the board on side. Every board meeting started with a presentation by yours truly to try to talk to the board members about what it was we were doing and where we were heading. It was very important to not develop too much space between where we were, what our thoughts were, and where the board was. It was very important to be with them. You know, our first board chair was Mr. Natishan, and he had not only been the Governor General of Canada, but also had many members of his family who had suffered strokes, and so he was absolutely committed. Very important to be in sync with your board, and the board understood where we were going, and in fact they rolled up their sleeves and got down into the deep and dirty with us to try to make things happen, and that was very important. The biggest hurdle is the people's conservative approach. In general, people don't like change, they don't want change, and they will resist change. And this was true from my colleagues, this was true from, you know, I gave many examples, this was true in municipal leaders. These were, it's very difficult to bring change. So the biggest hurdle was finding enough energy to keep going back and back and back again until the job was done. And you know, I did not succeed everywhere. There are still provinces in this country that decided not to listen to what we were saying, as the paper by Michael Hill would indicate to you if you looked at it. The tipping point always was the patients who came in with a stroke, paralyzed on the right side, unable to speak, and for whom everything worked in terms of the recognition of the symptoms, the trip by ambulance, the emergency room attendance to the needs of the patient, et cetera, and they walked out the following day from being paralyzed and unable to speak to going back to their lives. And so the tipping point was to be able to show examples like that. It was stunning. I mean, you know, when the network came on in 2000 and a neurologist on call at night got called with that there was a patient in the emergency room with a stroke, the answer was, make them comfortable, I'll see them in the morning. The network made me and all of my colleagues say, I'll be right there. And some of my colleagues, are you ready? Some of my colleagues sold their houses to buy houses that were close to the emergency room where they worked so that they could get there faster. So the tipping point was the data and the examples that was provided by patients who successfully received the benefit of the network's work. How long to develop? It really is a difficult question to answer, but we were under the gun, as you know, because we had to show evidence for success in our new approach by the time it came for midterm renewal and certainly end of the first cycle. Most other networks of centers of excellence by then had developed 3 or 4 companies that were new biotech companies that were going out there and selling shares, etc. We didn't have that, and so we had to show that in fact we had success. May I have the last question that was on that list?
Well, Dr. Elliot has written to say that she doesn't want to monopolize your time, so she's grateful for what you've answered already and says she can follow up with you at another time. So I'll move on then to the next question, which was submitted by Esha Ray Chowdhury. Pardon if I mispronounced that. And the question is, disease-specific KT initiatives seem more aligned to systems for purposes of changing practice than advocacy for recognizing variations in value-based perceptions about care practices. I would like Dr. Hakim's comments on this.
So I think for everybody's benefit, could you read the question again?
Yes, of course. Disease-specific KT initiatives seem more aligned to systems for purposes of changing practice than advocacy for recognizing variations in value-based perceptions about care practices. I would like Dr. Hakim's comments on this.
Yeah, there is no doubt that statement is true. Once you have learned that there is something that can be done, you've developed the knowledge that something can be done for stroke patients. And frankly, we're not the ones who did the trial of TPA in stroke patients. That information was available in the literature. It was available in the literature the first time we applied for a network of centers of excellence, and I did not succeed the first time. But I was told that what was missing was not the important things about stroke, but that I had missed the dimension of the social impact of stroke, because remember that networks of centers of excellence are supported by 3 granting councils, and I had not said enough about the social impact, and that's because, frankly, I wasn't sufficiently educated about the social impact of stroke. So we had knowledge coming into the network on day one. When we created the network of centers of excellence in stroke, we already had this knowledge. And yes, despite all of the hurdles that have already been mentioned, the mistrust of me in why was I pushing TPA, the difficulties we had in educating ambulances and ambulance attendants, et cetera, et cetera, et cetera. Despite all of that, there was knowledge that was hard and solid, and I was struggling with how to transmit this knowledge, transfer this knowledge to the spheres that were then going to be the receptors to implement change. It becomes very difficult when you don't have that, and I completely agree with the gist of your question. Thank you.
The next question comes from Russell Shearer. In terms of best practices, were impact targets set at the beginning of the network, and if so, how and what metrics were included to access overall impacts?
Yeah, it's a very important question because there was a lot of knowledge available in the literature already by the year 2000 about all spheres relevant to stroke, from prevention to treatment in the acute phase, to rehabilitation, and to reintegration of stroke patients into society. No one had put it all together. No one had calculated the economic impact of even going halfway, bringing in the knowledge that was available in these different spheres: prevention, treatment, rehabilitation, and reintegration. And so that was why we succeeded, is in being granted a network of centers of excellence, is that we sat down and said, bringing even some of these new bits of knowledge into practice on the ground, even if we succeeded to, and we actually had tabulated this, we succeeded to the level of 25%, 50%, 75%, here would be the impact of all of this, not only on patients and patients' lives, but the fact that the woman who comes in with a stroke and goes home the following day because she received the benefit of the network's work is going to be a taxpayer, is going to go back to work and be productive. And so all of that, you know, health economists have very effective ways of calculating these things that made it very clear that an investment of a few million in us would return billions to the Treasury. Thank you.
The next question comes from Dean Beefus. You may have addressed this somewhat already, but I'll read it out in case you have further comments. Dr. Beefus wrote, "Thank you for the presentation. Can you speak to the sustainability of the activities of the stroke network? Has national dissemination reached the levels the network modeled?"
Yes, and it hasn't stopped. I mean, you know, what we have done, for instance, there is now a program, the Center for Stroke Recovery. It's called the Partnership in Stroke Recovery, which was an offshoot of the network of centers of excellence, and it is now it has the ambition of being a national program, going from coast to coast. And in fact, some of the staff of the Canadian Stroke Network are now working in this Partnership for Stroke Recovery. And so yes, there is continued impact of the network's activities at various levels. You know, the Heart and Stroke Foundation has changed its tune a number of times and will do so again next June when they start their new year of stroke information. You will see some differences in the way they're going to present dementia, for instance, as being a vascular problem rather than one that is only Alzheimer's disease. So yes, the network is not around anymore, but I'm happy to say that its impact continues, including that Tony Hakim gets asked to do a webinar for another network of centers of excellence.
The next question is from Carol Berry, who asks, have results been duplicated in other provinces?
Yes, I think I touched on this, and I invite you all to read the paper that if you look up on PubMed, Michael Hill, you will see that there is a paper that has appeared recently looking at the impact of the stroke strategy implementation in different provinces, and the work continues, and yes, the impact continues. What about the provinces that are identified in that most recent paper as not having a stroke strategy? Well, you know, I'm hoping that the Heart and Stroke Foundation, because I can do it if I'm asked and would be happy to do it, would have the contacts to go to the laggard provinces and say, you're missing the boat, and I know that is continuing to occur. Thank you.
The next question is from Kevin Willison, who wrote, it is said that one way to encourage public input or public awareness is to use a community-based participatory research or similar approach. Here, public participation is actively pursued. Yet, such strategies tend not to be taught to healthcare professionals. Such strategies are not part of the curriculum in many Canadian institutions, in methodology-related courses, for example. The question is, do you foresee this to change?
Yeah, again, this comes back to my comment about never underestimate the conservatism of people in bringing a change, whether we're talking about curricula or whether we're talking about individual physicians. You know, we like to think that we learned it all and that we know it all, and please don't ask me to change. But you can be persistent. You can, I don't know how to say this, but imply that there will be embarrassment if you do not, if the person you're talking to doesn't bring in the changes. I told you my experience in having the data of the registry going from province to province, connected by the provincial Heart and Stroke Foundations, and meeting with deputy ministers of health and telling them that the report was coming out, and in some cases that was all that was needed for them to really mobilize and try to bring some changes. Sometimes it was not very deep, just enough to be able to say we did something about it. But other times, you know, people were messianic about it and decided to really take it on. And as I said, it continues. We need to bring into our curriculum, and in some medical schools it's already starting, more effective ways to bring about change than the traditional ones of Tony Hakim going from province to province to yes, involvement at the level of the research by the general population can be one of many effective ways of bringing in change. Thank you.
We have a number of outstanding questions, but we're running short on time, so I think we'll read two more and wrap it up at 2 o'clock. So one of the final two questions is from Lori Harada, who wrote, in Canada, food allergy is not recognized as a public health issue by agencies such as the Public Health Agency of Canada. Do you think that in order to change perception in Canada and government policy, We should consider advocating for change as one of the first priorities. Without this, it's hard to get government funding.
Advocating for change can only be successful if you have data, as we mentioned a number of times already. I know that you have data on food allergies. They are perhaps not broken down by province. At the end of the day, in this country of ours, change in the healthcare system is a provincial matter. And so you may want to keep that in mind as you look at the data that you're gathering to see where you may be able to push harder if you know that in a particular place food allergies are a higher percentage occurrence than in others for whatever reason. That may be important, because at the end of the day, even though we and you are national programs, the changes occur provincially. And so you need to keep that in mind as you go forward. Thank you.
Well, I had said 2 quick questions, but we're really coming up to the 2 o'clock cutoff point, so I'll turn things over to you, Diana.
Well, thank you very much, Marshall. Thank you all for attending and for your thoughtful engagement with today's speaker. We hope that the content was useful to you in planning your own high-impact research and knowledge translation strategies. AllerGen would welcome your feedback on today's Planning for Research Success session. This is the final session in AllerGen's inaugural webinar series for 2015-16. So immediately after this webinar ends, you'll be prompted to complete a brief survey to provide us with feedback, which should only take a minute or 2 to respond. Your feedback will help us plan the next series of webinars for presentation in 2016-17. Again, thank you for taking part in today's webinar, and on behalf of all of us, a very special thank you to today's presenter, Dr. Antoine Hakim from the Stroke Network NCE. It's been a very inspirational, very informative session, and I know all of us benefited greatly from your experience and your mentorship today. So have a great afternoon, everyone. Bye-bye.
Bye. Thank you.